Welcome to the Healthcare Hot Seat with Tina D. Badham and Lorie D. Owens, where the people who keep healthcare moving and the people who depend on it finally get a seat at the table. Take your seat. The conversation starts now. Welcome back to the Healthcare Hot Seat, where we bring real conversations, real experiences, and real solutions to the forefront of healthcare. I'm Tina Badham, and today's episode is extra special because I'm joining you all the way from the UK for an in-person visit with the Homecare Association.
And I'm Lorie Owens, joining from the States. Today, we're taking a different approach. A two-part international series that gives you a side-by-side look at home care across two countries.
Across America, home care is not a single government system. It's a highly fragmented, highly decentralized mix of private business, government programs, and independent registries that vary significantly by state. In the United Kingdom, home care is widely referred to as domiciliary care. Unlike the highly fragmented American system, UK home care is heavily tied to the government through the National Health Service and local authorities, though it is not completely free for everyone.
We are honored to welcome Dr. Jane Townson, Chief Executive of the Homecare Association for the UK. Jane is a respected voice in home care, known for her leadership, her advocacy, and her commitment to strengthening care that is delivered in people's homes.
Dr. Townson, welcome to the Healthcare Hot Seat. We appreciate you taking time to speak with us, Tina in person and me from across the pond, as we explore how home care works in the UK, what's working well, and where the system is evolving.
Well, thank you very much for coming and welcome to the UK.
Thank you. So Jane, let's kick it off with the basics here. Can you walk us through the structure of home care in the United Kingdom? Who provides it, who pays for it, and how people access those services?
So there's been huge change in the UK over the last 30 years because way back before 1990, all of the care was commissioned and delivered by local authorities. Okay. And then there was a change in law to enable outsourcing of care. And the idea was to create competition, to encourage innovation, to enable entrepreneurs to contribute. Yes. And just to come up with some more flexible and different ways of doing things. So fast forward now, about over 95% of home care is delivered by independent providers. Okay. The local authorities in some places have retained some capacity internally, and that's partly they will tend to have reablement teams, but also they need to have some capacity in case something goes wrong in the market. Right. And they've got to step in. So, and over the last 10 years, we've seen rapid growth in the number of organizations. So back in sort of 2018, there maybe were around 9,000 locations of home care. And now we're up to something like 15,000.
Wow, that's a lot of growth.
Yeah, sort of 15,000. The care homes originally were, there were more locations of care homes, right, but they've sort of slightly declined and home care has increased. So now there's roughly the same number, sort of 14,500 locations of care homes and 14,500 locations of home care.
Wow, that's amazing.
But the market is very largely run by small and medium enterprises. So over 85% of providers are SMEs with fewer than 50 employees. And in actual fact, in home care, 42% of them have got between 1 and 4 employees.
Wow.
So a lot of extremely small outfits. And
Absolutely.
That also creates some challenges as well, which I can touch on later.
Yes.
And in the market, there are a wide diversity. So from very small providers to very large providers, The largest home care provider in the UK is City and County Healthcare Group, and they deliver somewhere between 300 and 400,000 hours a week of home care.
Wow. Yeah.
And the smallest ones will be delivering, 50.
Wow.
So it's very sort of variable. And then the providers, the smaller providers tend to do a bit of a mixture of state funded and private pay funded work. And we can come back to that in a minute. The larger organizations tend to focus more on one or the other.
Right.
So the larger organizations tend to be mainly state funded or mainly private pay funded. There are some exceptions to that. And we don't have accurate data on the number of people buying their own care. The market analysts, Lenguisson, estimate roughly 80% of home care is purchased by the state, either local authorities or the NHS. But there is evidence from software suppliers to our sector that actually the number of self-funders is higher. But there's no way of collecting the numbers accurately.
The data's hard to get. Yeah.
What does that small provider represent out of all of the UK? Just out of curiosity. I know that wasn't one.
What percentage of the market?
Yes. Yeah.
So it's over 85% of the total provision is delivered by small and medium enterprises. And that's the same in care homes and home care, but it's more extreme in home care.
Got it. And so building on your previous conversation, commissioning was something that we had briefly discussed when we talked a few weeks ago, and that plays a huge role. How does commissioning work? And what would you say is the biggest strengths and weaknesses to that current model?
So the first thing it's probably important to explain is that the United Kingdom is made up of England, Scotland, Wales, and Northern Ireland. And we refer to England, Scotland, Wales, and Northern Ireland, the Scotland, Wales, and Northern Ireland as the devolved administrations, because legally the responsibility for social care is devolved to the individual nations as part of the UK. So that means that the Welsh government, the Northern Ireland government, the Scottish government can create their own policy and the way that they do things. And we do see quite big differences in what goes on. So if we talk about England first, the state, so that's local authorities, councils, they buy most, substantial amount of the home care, but also the NHS, the National Health Service. We estimate about 25% of income into the home care sector comes via the NHS. And there are at the moment 153 local authorities with the statutory responsibility for social care, and they all do things differently. And there are, I think, I've slightly lose track because they keep reorganising, but there's probably around 42 integrated care boards, NHS integrated care boards that buy home care from independent providers. Altogether across the United Kingdom, there are 276 public bodies that buy home care from independent providers. But right now, the England government is reorganising local authorities. So the number of what we call top tier local authorities that will have responsibility for social care is going to increase from something like 153 at the moment to about 200. So we don't quite know how that's all going to play out, except that it's a lot of reorganisation that's going to distract people quite a lot. And the integrated care boards in the NHS, they're all having to make substantial cost savings. So there's a lot of rationalization and people changing roles going on. So it's quite a time of So if we perhaps just choose one local authority, I'm not going to mention any by name, but they will go about buying home care from independent providers in different ways, and they're free to do that. So they've got that power. So some of them will go out to tender and invite bids to be on a so-called framework contract. So some of them don't have any limits to how many providers can be on that. So you, as a provider, will submit information that they've asked for. They might ask for your quality rating. They might ask for information about your financial status.
Oh, wow.
But sometimes it's quite light touch.
Yeah.
And then if they agree to have you on the framework, then as a provider, you're there. And then every day, essentially, any new person that needs care, they will put the request for that care on this sort of bidding platform.
Right.
And then all of the providers just have to bid for the work.
Oh, wow.
And quite often, usually it's the winners of those bids, micro bids every day, are the ones that bid at the lowest price.
Wow.
Some of the councils fix a price, and then it's just who presses the button fastest.
Right. Yeah,
right. But the problem with it is that in some local authority areas, that they're quite geographically large, and they don't divide up the area. So you could be a provider bidding for a piece of work that might be 20 miles away from you. And a provider that is right next door to the person that needs care might not win because they didn't bid at a low enough. So the consequence of that is that the care workers end up often having to drive there in this kind of very uncoordinated. I mean, because they've split the hours that they purchase across too many providers. So it becomes very fragmented. And as you probably know, that, delivering home care efficiently does require a certain volume of work in a fairly tight geographic area, so that you can then create rounds for the care workers that are compact and easier for them. And then on top of that, the councils typically only pay for client contact time on a 0 hours basis.
So not the driving to and
no,
from.
And so the driving and all of the working time, that counts as working time for national minimum wage purposes. So it means that the hourly rate that the provider receives needs to be enough to cover not just the wages and statutory employment on costs for the client contact time, but also all of that for the time spent traveling, waiting, training, and so on. And this is really why we have ended up with so many problems, because the amount that the councils are offering is massively inadequate.
Right.
Yeah.
Especially given the rising cost of everything right now. And, kind of shifting gears a little bit to talk a little bit more about the workforce. I mean, we know the workforce is really the backbone when it comes to healthcare. So I am genuinely curious, what would you say are the most pressing issues for those healthcare workers across the UK right now?
I think the first point I'd like to make is that the social care workforce in the UK, or in England, let's just say, is actually slightly larger than the NHS workforce.
Wow.
So it's huge.
That's incredible.
About 1.6 million filled posts.
I would never have guessed that. That's amazing. Yeah.
And unlike the NHS, there is no national workforce strategy.
Right.
And it's all sort of left to, basically the employers, the providers.
Right.
But they can't really, you need to do the workforce planning at least a local level.
Right.
And that just doesn't happen. And that has been a large problem, especially because they enabled international recruitment, which in 2022.
Right.
And that happened in an uncontrolled fashion. So suddenly we had sponsored workers arriving. Many of them ended up in London and the southeast.
Right.
So then we ended up with too many workers in some places and not enough in others.
Oh, wow.
And having too many workers causes as many problems as not having enough, because there aren't enough hours to go round.
Correct.
And for the sponsored workers, they have to have full-time salaried
it's very
roles.
Specific, right?
Yes,
yeah.
And they've got no recourse to public funds. So if they don't get the work, then they're destitute. So
really...
the workforce turnover, I mean, I think it's a problem internationally. I haven't met a single country, even the ones where, in Scandinavia, where there's a lot more funding and so on, where they haven't got the same problems.
Absolutely. Yeah.
Even places like Sweden, they've got a lot of non-Swedish nationals and high churn. And some of it is about pay and terms and conditions.
Right.
But I think maybe as much, if not more, is around sort of moral injury. So the workers want to meet people's needs, and they find that they can't with the constrictions of and the restrictions on time and what, and some of the local authorities in England can be quite prescriptive.
Right.
When people are paying for themselves, it's different because they're the ones calling the shots.
Yes,
they're effectively the commissioners, and the money, they can choose how they use it. So, I'm going to give a silly example to illustrate, but if somebody said, I don't really want my breakfast today, I want to go and chase seagulls in my pajamas, then that would be perfectly fine.
But if it's being publicly funded.
But if it's being publicly funded, it's you have to give Mrs. Jones her cornflakes at 8 o'clock in the morning, and that's that,
And what happens if that's not done? I'm just genuinely curious.
Well, that's another problem. I mean, we do have a system of regulation, which we will come to, but it isn't working as effectively as it could. But then it will be down to the individual family contacting the office, saying there's been a missed call. I mean, now we've got much more digital solutions in use. I think we're up to about 83% of home care providers have got digital social care records and digital rosters. So that does help the employer actually see where people are and be able to sort of check. But
which also I think creates problems in itself when you talk about workers, because not everybody loves being tracked, and there's a lot of conflict around that as well. And I think we see a lot of that in the US also. So
but I think the issues with pay are related more to insecurity of income and lack of just inadequate total income. The headline pay rate, which our government has got a bit fixated with, we don't see as the major factor, because, for example, if the headline pay rate were like our minimum wage in the UK is £12.71 an hour, pence an hour. But let's say you were to pay someone £20 an hour, which is a lot more. But if you can only give them 3 hours of work a week, that isn't as useful to them as having 30 hours at £12.71. So we think that, that the sort of total income and knowing from one week to another, and that's a challenge in home care, as we all know, because the needs of the people that we're supporting fluctuate so much, don't they? So you might have 2 care workers 4 times a day for Mr. Smith, but then he goes into hospital or dies or goes into a care home, and suddenly all of that work is gone, and it takes a bit of time to find another person for those people to support. The more hours that you're delivering as a provider, the easier it is to buffer those fluctuations. But with all these tiny providers with only a few hours, that it just makes the work much more sort of up and down. And then, that creates some issues, because the government in England has introduced a new Employment Rights Act 2025. And some of the measures have come in already, but some of them haven't yet. But one of the measures is that employers across the whole economy, not just in care, have to offer guaranteed hours to workers.
It's going to be challenging.
The workers can say no. But and it'll be on a 12-week sort of rolling cycle. So whatever they've worked in a 12-week period, if it's been reasonably consistent, they have to be offered that as an ongoing contract. We don't know how that's going to be possible to implement unless the local authorities and the NHS go about buying the care in a different way.
It's going to have to be structured differently. I mean, to be able to provide that ongoing.
And none of them want to, you see, because this method of these procurement portals and buying care from everybody individually saves them money. Or so they think. Whether it actually does to the whole system is another matter.
And I think it's all about the perceived value, right? And that's kind of tricky to get around, because you have to be able to have statistics to prove it otherwise. So that makes it challenging.
To be fair to local authorities, they've had their budget squeezed by national government progressively since the crash in 2008. And of course, at the same time, the need of our population, everywhere globally, is seeing aging populations and growing complexity of need. And interestingly, in England, about 50% of the local authority budget is spent on care for over 65s and almost the same on under 65 care.
Yeah.
So people that have perhaps been born with disabilities,
Right.
or they've got learning disabilities or physical disabilities of some kind, they're living longer as
Yes.
well, and their needs are quite complex, and quite often they'll
Yes.
have 24/7 supported living.
That's right.
So councils are struggling to meet their needs as well as the older population.
Right, which is also increasing
Yes.
rapidly.
We touched on some of this already, Jane, or you've at least kind of introduced this subject. There are ongoing discussions about fees and rates, recruitment pressures, employment models. How do these factors shape in the quality and the provider stability?
Well, obviously, if providers don't receive enough money to cover their costs, they have to cut corners.
Right.
And we conducted a large freedom of information study in 2025. So that means that we have freedom of information legislation in the UK, which means that if you write to a public body and ask for data, they have to give it to you unless they've come up with a very good reason not to. So we wrote to all 276 public bodies across the UK that buy home care from independent providers, and we asked them questions about how many hours they purchase, how many providers they purchase from, what their lowest fee rate, highest fee rate, average fee rate, all of that. So we, Adrian and our team sort of analysed it, and we produced this big report that's got all of that in there. But the analysis shows that 29% of public bodies are buying home care at fee rates that don't even cover direct employment costs at the minimum wage, never mind contributing to the other running costs, because that hourly rate, as you know, it has to pay the wages of the worker and the employment on cost, but it also has to contribute to your other running costs. So you have to have a registered manager, you have to have people doing the planning and the coordination, you have to have IT and telephony, you have to have insurance, you have to pay the Care Quality Commission, that's our regulator, fees for the privilege of being registered, and then all of the normal costs of running a business, like you've got to have an office and rent and rate and utilities and,
as we say in the
legal
US,
fees and
keep the lights on, right?
Yes,
That's
exactly.
It,
And so we do a calculation every year. We call it our minimum price for home care, worked out from first principles and also from provider data on typical operating costs. And our figure for 26-27 has come out at £34.42 an hour. So that's the amount that we calculate providers need on average to be able to run a good quality service, meeting all of the care regulations and the employment regulations. Only one public body in the UK is paying that. 29% of them, as I said, are not even covering the employment part. And that number has quadrupled in the last 2 years.
And I imagine it's only going to continue to grow.
And so the kind of behaviours that we see then are that the providers, instead of staying for a full 30 minutes, will stay for 10 minutes and they'll do 3 10-minute calls in 30 minutes and then charge the councils for 30 minutes. I mean, it's fraudulent, but
it's how they feel
they
have to
keep
do
going.
it to make money, right?
And or they don't pay the minimum wage for all hours worked. So the most typical problems are not paying for the travel time and the waiting time and training time, or they won't properly train and supervise their workers, which concerns us because of the need is growing and people have got basically people don't receive state-funded care unless they've actually got quite significant health needs. That'll be dementia, frailty, or things, conditions like multiple sclerosis or
ALS,
something.
things like that.
And quite often we'll have quite, no support or limited support at home, because anybody that has got someone that might be able to support them, they are leaned on. And there are over 5 million unpaid family carers,
which is hard too.
Yeah.
That makes it a direct correlation to the quality of care that can be provided. Less skilled workers because they're not getting the training that they need, and there's not as much on the compliance side of things happening.
And the thing that we're most concerned about is that the ethical providers that want to do the right thing and don't want to compromise on quality, they're not winning the work because they can't bid at rock bottom prices because they can't cover the costs of doing it properly.
Absolutely.
And if the regulators were on it, that would be picked up. But unfortunately, the Care Quality Commission lost its way in the pandemic. They had a change of leadership. They decided to reorganize the whole regulator and change the IT system whilst working remotely in the middle of a pandemic.
Oh, wow.
And it all went horribly wrong. And so now we've got, we recently published an analysis, but of the community social care registered locations, there's, as I said, about 14,500 of them. 36.9% have never had an inspection and have no rating, and 46.6 have a rating 4 to 10 years old. Well, if your rating's 10 years old, it's just not worth the paper it's written on. So the combination of those two figures is 83.5%. So that means that over 4 out of every 5 community social care location has no up-to-date rating, either no rating at all or no up-to-date rating. So as a member of the public, you've got no way of telling whether something is good or not. Now, to be fair, if a member of the public raises concerns with the Care Quality Commission, they'll go and investigate. Right. So the kind of the most unsafe, worst examples they're picking up. But there must be a lot of undetected poor practice going on out there. So we're trying to support the regulator. We've always been great sort of supporters of having standards and regulation, but we need the government to support the regulator with some extra funding to try and catch up. Otherwise, it never will within existing resources.
So within the regulation, like the regulatory board that they do here, and I don't know how this really translates, across the pond here, right? But are there like audits that they do? Are they required to do so many audits on home care associations? Like, how does the regulation actually work? Like, what drives those quality
factors? So I suppose
the
good thing, and one of the things that's different from the United States, is that we have one regulator for the whole of England.
Right.
You have different ones for different states.
We do. Yeah, we do.
But then, one state in the United States is probably bigger than in England anyway.
Right. Yeah, that's not untrue. Yeah, it's very large.
But the Care Quality Commission is responsible for all of the regulation of care in England. Wales, Scotland and Northern Ireland have their own regulators. In theory, the Care Quality Commission should be inspecting every location at least once every 3 years. Okay. If somebody gets, and they have different ratings, so outstanding, good, requires improvement, or inadequate. So if any service gets an inadequate rating, they will have conditions put on them, and the Care Quality Commission's policy is to go back and inspect at the latest within 6 months. But at the moment, they're not meeting that. Yes. I was dealing with a case this week where their provider had an inspection 15 months ago and was rated inadequate, and they've made lots of improvements, but CQC hasn't gone back to check.
Wow.
And then the consequence of that for the provider is that they're not allowed to carry on delivering local authority work until they've got a better rating. And so they're then losing business and income.
Yeah.
Which obviously then affects sustainability. And the CQC they used to do a routine set of inspections. So if they don't receive any notification, so for example, if a member of the public emailed or called them and said, there's very unsafe care going on in such and such a care home, or there were no staff on duty, or, whatever it happens to be, then the CQC will go and check. And they also work quite closely with the local authorities because they've got a contractual responsibility. But in the past, the local authorities used to do contract monitoring. So they used to pick up performance related issues themselves. And some of them are still doing that and doing it very thoroughly, but many of them are not. And some of our larger members, who are operating in 100 local authority areas, are reporting that they've only ever had 4 contract monitoring visits, and 2 of them were from the same local authority.
Wow.
So we are concerned that there isn't the oversight that there needs to be, especially given the level of need. I should say that in other administrations, for example, in Northern Ireland, their regulator is managing to keep on top of it because there aren't as many providers. And they're managing every 2 or 3 years.
That's,
I think, maybe even every year, which might be a little bit over the top as well. There's a bit of a balance.
Right.
I want to scoot back to get back on a quality type discussion. If it's been said that complex conditions such as dementia, neurological conditions, people with long-term disabilities in general need more consistent support and services. What do you think would strengthen the quality and the safety of those individuals? Like, what would you change or make different?
Well, we're seeing a shift already in that more of our members are employing nurses than they ever used to. And that's good because then you've got that clinical oversight.
Right.
The challenge that we've got is because of the fragmentation, because there are so many tiny providers, you can't afford, or there aren't enough nurses to have one in every organization, and there wouldn't be enough work for an individual nurse in a tiny organization. So one of the things that we've been suggesting is that they, at a neighborhood level, we consider creating enhanced health in home care teams so that there's some clinical support for a collection of smaller providers.
Right. Yeah.
We actually are trying to push the local authorities to go to think about commissioning larger volumes. And we're not talking about massive. We're not suggesting that the market suddenly becomes a few gigantic companies. That's not it at all. But at a local level, an individual small and medium enterprise can handle delivering, say, 2,000 hours a week, something like that. And at the fee rates that the councils are offering, you need that sort of volume to manage to get the economies of scale to be viable. So I think once you've got a slightly larger, like slightly greater concentration of hours, then it makes it easier to hire people that can provide that clinical oversight and the training. And obviously, as Lorie said, the continuity of care becomes really important. But that's a real issue because we're seeing this cost saving mentality of the public bodies, removing trusted long-term providers from people in the community to cheaper providers to save money. So I was talking to one of our members recently who's been supporting someone with multiple sclerosis for 10 years in their own home. And then suddenly somebody comes along and says, oh, we found a cheaper provider. And then this poor person with no choice and control, even though our legislation, the Care Act 2014, specifically gives people rights to choice and control. When in practice, they're just told you've got to move to this cheaper provider. And that is just appalling. And often that ends up in a breakdown of the care or the person's condition, and they end up in hospital, which probably ends up costing the whole system far more. Never mind the suffering to the individual and their family.
Absolutely. No, and I think that's I think that's kind of a problem that everyone faces. I mean, hospitalization is also a very important term for us in the US. We are always trying to battle against that. And I think like you say, there's constrictions in there with that. And if they're not really given a choice, even though technically I guess they're supposed to, it can definitely affect the continuity of care, and thus affecting the quality. And there's a whole lot that goes into that.
So for many years, we've home care providers have worked collaboratively with NHS colleagues sort of on the ground. So the NHS has acute hospitals, big, but also community services as well. So they'll have some community hospitals which are sort of smaller, and maybe people will go after being discharged from a big hospital. They'll go to a smaller community hospital just for a little while to sort of rehabilitate, or they may go straight home. And then there are community nurses that are employed by the NHS. We call them district nurses, and they will quite often delegate certain healthcare tasks to home care workers. So typically things like peg feeding, maybe even wound dressing, increasingly insulin injections, catheter care,
a lot of the more high risk
medicines
things,
management, and or that's been fairly standard. And the proviso is, of course, that they have trained and a supervised competency has been assessed. But increasingly, we're seeing that there's a shortage of district nurses, and the NHS is less willing now to train and oversee care. So one of the things that's been happening recently is that they've the NHS commissioners have been saying to home care providers, we're not going to commission this work unless you get registration for treatment of disease, disorder and injury yourselves, which means they've got to hire clinicians, which is obviously expensive, difficult. There aren't enough to go around. So we're concerned about that because we think that the NHS is doing that partly to transfer risk and also costs onto independent providers. And our legislation in the UK is that NHS care should be free at the point of delivery.
In talking about that, because the NHS obviously does have some responsibility to provide some of that, when we're talking about like a funding model for home care, if they were to restructure that today and they came to you and they said, Jane, tell us what are the non-negotiables? What has to go into this funding model? What would be your suggestions to them for that?
Well, interestingly, we've just got a new prime minister, yet another prime minister.
Yes, I saw that.
Andy Burnham.
Andy Burnham, yeah.
And
we did see that.
Back in 2009, 2010, he was actually the Secretary of State for Health. And he was very exercised back then about social care. And he had proposed then, he wrote a whole white paper about a national care service. Now, at that time, his vision was some kind of integration between health and, NHS and social care. I think that's maybe shifted a bit because that probably doesn't solve anything anyway. But what he's said recently, since in the run up to him becoming prime minister, is that he would like social care funding to be accessible to citizens on the same basis as NHS funding. In other words, sort of free personal care at the point of delivery. Now, that actually happens in Northern Ireland, and it happens in one local authority in England, in Hammersmith and Fulham Council. And in and of itself, it doesn't solve the problems if there's not enough funding in the system. But I do think we would support that as a concept, because quite a lot of the problems for citizens come at transition. So they might be in a hospital and then they get discharged back home, let's say. They may have 6 weeks of NHS funding, but then there has to be an assessment of their need and their financial situation. And quite often at that point, they find that they've got to pay for it themselves. And that comes as news to them because a lot of people don't pay any attention. It's a bit like if you don't have children, you don't pay any attention to what's going on in education.
Absolutely. Yes.
If you've never had any contact with the social care system, you don't know what it is, and that you don't realise it's separate from the NHS.
Absolutely.
Everybody's heard of the NHS because people have interactions with their family doctor and what have you. So that often causes a lot of delay because families suddenly realise they've got to pay, and then if someone has to go into a care home as well, and if there's nobody living in their house, they can be forced to sell their house to pay for the care. And that causes a whole bunch of issues as well.
And I imagine delay in care. A lot of people will not seek it for that reason.
Well, exactly. And then of course they deteriorate. And in Northern Ireland, to some degree, that's sort of, there is free personal care there, but the Northern Ireland government's only got a certain amount of money. So they have to ration it as well. And there's been a lot of media and political pressure about hospital discharge. So they've directed funding at that. And then that's meant that people at home in the community have been neglected. So they're deteriorating. And instead of being able to then have home care, they're suddenly having to go into a care home because their needs have got to the point where they can't be supported at home.
Oh, wow.
So that's, the free personal care only works if there's enough money in the system. In places like the Netherlands, because they've got social insurance as well, and I think in the United States, it'll be interesting when we get on to talk about that. But when there's more money, it takes away some of the problems.
The pressure, for sure.
There have been some proposals, Jane, about more standardized national models approaching contracting. How might a unified model change the system?
I don't think they're going to be able to unify it completely because the statutory responsibility for social care lies with local authorities, not with national government, which is different from Australia, where it's the other way around. And Andy Burnham, our new Prime Minister, is very keen on devolution. So I think that his instinct would be to strengthen local leadership and control over what happens, rather than trying to centralize it.
Yeah.
Although, in the Labour Party manifesto ahead of the general election in 2024, they talked a lot about a national care service, but so far no one has managed to articulate what they exactly mean by that.
Right.
Some people interpret that as, he wants to create, or they want to create a structure like the NHS. Well,
Right.
I don't really think that is feasible or affordable. So I
Right.
don't think that'll happen. And then they said, well, we want national standards. Well, many of us would argue that we've already got a large number of national standards that are just not very well enforced.
That's it.
We've got a whole system of regulation, and the actual regulations themselves are okay.
Right.
It's just that there aren't enough inspectors. They're not doing enough inspections
Right.
and everything. But I do think it would be good to have, we're advocating for more of this sort of a patch-based approach. I mean, actually, there are two potential ideas. One is, I really like the Australian model, where they've gone for a completely consumer-directed approach. So what happens there is that if, as a citizen, you think you need help at home, you register on the national government website, and then somebody local to you comes and assesses you. And they've got they've now agreed to use one assessment tool for the whole country.
Okay.
And then they've got 8 levels of need that they've defined. And then for each level of need, so let's say Mr. Jones is assessed at level 8, which is the highest level. There's a government subsidy associated with that level of need that is the same wherever you live in Australia. So then Mr. Jones, he doesn't physically get hold of that money.
Right.
It's held for him by a third party called Australia Services. But then Mr. Jones is effectively treated as though he were paying for his own care, and he can go and choose his own provider. So let's say he chooses, Lorie's care.
Yes.
He sits down with Lorie, agrees a care plan. She delivers it. And then at the end of the month, Lorie invoices Australia Services for the money. And, then you'd get away from all of this, procurement portals and commissioning arrangements. So that's a radical approach.
Right.
The potential downside of that is if you don't control the number of providers, which Australia has, then you've got the fragmentation problem, and you can't get the economies of scale. And, the digital transformation agenda, which we haven't really talked about, that's very difficult when you've atomized the workforce down to units of one. You need providers that have got some scale.
Yes.
So the other option is to go to more patch-based commissioning or neighborhood-based commissioning. So you don't have, 300 providers. You have one per neighborhood that each is doing 2,000 hours.
Right.
So we're not talking, like I said earlier, not massive providers, but enough to be able to create decent rotas.
Right.
And then, of course, if you've got sort of one provider in a neighborhood, it then makes it easier for the district nurses in the NHS to feel confident that because they can build a relationship with one provider much more easily than they can with hundreds tiny little ones. And then, they can then provide the clinical support, do the delegation and so on. And it makes the sort of digital, the record sharing and everything so much easier. The home care providers can then be part of the multidisciplinary teams in neighborhoods, and they're all working with the same people.
Right.
And actually, we argue that the home care workers know the people better than any other professional because they're in and out of people's homes multiple times a day, and sometimes 24/7 they're there.
Right.
And they can act as the eyes and ears. And if they need help, then they've got, direct route in to the multidisciplinary neighborhood health teams to ask. So that's what we.
No, I think that's I think that makes a lot of sense. And I am curious, how you would, based on what you know about the US system, how would you kind of compare, I guess, like the biggest differences really between the US system and the UK system right now? Just based on what you know, obviously.
I think there seems to be more money in the system. I mean, I think you've got similar problems with workforce for sure.
Yeah.
And all the issues with migration and insecurity of income and high turnover, those things. I'd say my experience, because in my previous role, I was a care provider CEO, and we delivered home care, housing with care, supported living for people with disabilities, and operated 30 care homes. And when I was looking to upgrade our IT, I couldn't really find anything suitable here.
Yeah.
But in North America, there were companies that have been doing that for 20, 25 years before us. So I would say that the digital transformation, the digital tools that are available to providers in the United States are much more sophisticated and much more useful. For example, if you're a care home provider there, you can literally sort of press a button and generate a hospital passport. All of the information that somebody needs if they get admitted to hospital is there. And, also things like lab results can come back straight to the care home.
A lot of sharing of information. Yes.
But you've got some different things around, like end of life care is done by, within regular home care providers. You've sort of got a separate hospice type service.
We do.
So I think there are some, things that we could learn from. I think there's more of a consumer culture in the United States. I think people are more used to, fighting their corner and asking for what they want. And I think the insurance model perhaps makes that easier. I don't know.
We do have some state regulatory things that go in there, but overall, a lot of our stuff actually does come, and we'll talk about this certainly more in the second episode, but a lot of it does come directly from our Centers for Medicare and Medicaid Services, CMS. They regulate a lot of that because most of our providers, those are the referrals that that they take in a great portion of, especially as population starts to age. So, on top of that, we do have some of the local state regulatory things that also have to be met. So it can be quite challenging, but I think
you've also had a history of more of those retirement living, later life living sort of developments, particularly in some places, places like Florida.
That's everybody's go-to.
But I think, we're a long way behind compared with other places like the United States, say New Zealand, Australia. And, even in other countries, they're not still a relatively small proportion of the total market, but I do think they're helpful.
Yes.
And, in places like Japan as well, a lot of older people have moved into the cities. And obviously that's bad for some of the rural areas because it's whole sort of abandoned villages. But on the other hand, you've got people in a more concentrated, sort of dense population area, which makes delivery easier.
Yes.
When you're sort of, having to drive miles around the countryside, it makes it a lot harder. And in the UK, what happens when people retire, they do the opposite. They all move out of the cities to the rural and coastal areas, where the geography is, the population density is really low, and the workforce is, because they're young, the workforce is younger. They're in the cities, and the people that need the care are on the coast and the rural areas. So there's a mismatch. And unless somebody comes up with some policies to either encourage older people to remain in cities or to incentivize younger people to move to the coastal and rural areas, we're going to have a big problem in 10, 20 years' time, even bigger problem than we've got now.
Rural care can be very, very challenging. We have also very big cities, just thinking about Boston, New York, where although there's a high volume of population that you're going from place to place, the amount of traffic and the time spent getting to one patient to the next can present its own challenges, which can equate to about the same amount of time, just not the amount of miles between patients.
We calculate that the home care workers in the UK collectively drive over 4 million miles a day. And that is way above international benchmarks because they're all having to do this sort of zigzaggy thing because the rotas are not compact.
Yes.
And some research that was done in Bristol showed that if you were to reorganize exactly the same visits on the same day, the same round, you could have actually reduced the mileage by 65%, which is not only reduces costs and time and wear and tear for the care workers, but also the environment. And, with fuel prices being really high thanks to, the issues in the Middle East, that is a big problem as well here.
Very true. I do think that some of our EMRs even have a lot of tools here that assist us with optimizing our staff, optimizing the routes and things of that nature. That does go back to that comparison of what technology is utilized here in the US compared to what we see elsewhere.
I suppose, I would just sort of like to say that I do think, well, it's true in both countries, we've got a massive opportunity for our workforces, like a preventative workforce.
Yes.
And so many people end up in hospital unnecessarily.
True.
And actually people want to live well in their own homes.
Yeah, of course.
So I think we've got the people on the ground, and it's just giving them that more, that slightly greater support and a bit more funding, which is, in the great scheme of things, much less than goes into the NHS.
Absolutely.
And we could make a massive difference to many more lives.
No, I think that's very true.
Jane, what are some ways our organizations could partner to elevate home care, whether it's shared research, joint advocacy, campaigns, international workforce initiatives, or even cross-country learning exchanges?
I think, to begin with, just sharing information about what's going on is really helpful, because
Agreed.
You get ideas from seeing what works and what doesn't. I mean, I think the things that go wrong are as instructive as the things that go right.
Yes.
And, I've been very interested to learn from colleagues in places like Australia and New Zealand. So I think just having more opportunities to talk across care associations internationally. There are some academics in the UK that during COVID set up a sort of group, long-term care, and they were particularly at that time monitoring care homes, but I've sort of been encouraging them to branch out a little bit. But I think we could create a kind of international group, and that there are some home care associations in places like Italy that are doing webinars and that kind of thing. So we could kind of maybe see if we could create some international home care association or coalition anyway.
Yeah, and that's what I mentioned, like a shared platform even that everyone can potentially benefit from. But no, I think an international board almost where it's not necessarily a paid thing, but something where everybody can just come together and discuss, hey, this is what we're doing in our country and this is what's working here and what's not working. And, just to get those ideas and bounce them off and be able to find better ways to do things, even with the regulatory compliance type things that you have in your own country, to be able to find better ways to get around that and to make sure that we're following the rules, but still maximizing the care that patients are receiving.
We find that our members are really interested in learning what's going on in other countries. And at our annual conference, 2 years in a row, we've had international speakers. We've had, from Australia, from the United States, from Spain, from where else? Sweden. So I think that's really good, because everybody's so busy with their heads down trying to keep the show on the road today that they don't always have that time and space and opportunity to look up and think about how things could be different.
Yeah, I agree completely.
The more we align on our messaging, the more we show home care is essential and not optional. And the harder it is for policymakers to ignore it.
I think there might be something as well about just explaining to the uninitiated what's involved in home care, because particularly with the tech entrepreneurs, my experience is that you get people coming along saying, hey, there's going to be so many more older people, and I've come up with this really cool device that I think is going to change the world, but they haven't actually really understood what goes on the ground, what the people drawing on care actually want and need. Some of the kind of potential barriers. So there's something about articulating the needs of the sector and working in partnership more with those clever people that can come up with these things.
Absolutely. And, and I think ultimately, and this is something that we say quite often, Lorie, myself, the home health industry in America all around is, realistically, home health is the future of healthcare. Like when you think about it, not that hospitals will ever be rendered useless, but I think too, you get into a place where the hospitals, that really should be reserved for the acutely ill, the ones that can't be treated at home, whereas home care is meant to treat those people who can be treated from the comfort of their own home. So I do think that, looking at that unified narrative, as our country, your country, Sweden, everybody else that's involved in that, coming together and just kind of saying, look, we have to protect this. We have to make sure this is the time now to invest in it, to make sure that we are moving towards having health, that home care is the future of our healthcare industry. So
yeah, because we know that people with frailty in particular do very badly in hospital.
Absolutely.
They usually deteriorate, and when they come out, if they come out, they're in a far worse condition.
Yeah, even me. I nobody wants to stay, 2 weeks in the hospital when I could maybe stay a couple of nights and then go home and have that care there. That's a whole lot better. And I think that that's where we kind of end up in the recognition that home care is very vital. It is important. And I don't think that anybody doubts that. I just think like we've spoken, it's the knowledge, it's the deficit in the knowledge base, right? It's not really understanding what that means and what that could look like if it's done properly and efficiently.
I think we had a public inquiry about COVID-19 pandemic. And one of the things that we spoke about when we gave evidence was what we described as a hierarchy of invisibility.
Right.
So the acute hospitals are very visible to the public, and somehow the money gravitates there. Even if you look at the health service, the sort of community services like the district nurses are not as visible.
Yes.
And they, within the NHS, feel like the poor relation. Then within care homes are more visible. So they tend to get more media attention and public attention. And quite often care homes are used as a sort of shorthand for the care sector. In the UK, the government has commissioned Baroness Casey to do a sort of review of social care reform. And she has got some money together to commission a sort of big conversation with the public, which starts this summer. So we'll see whether that gets any media traction and coverage. And of course, if the Prime Minister stands there talking about how he wants to reform social care, that will help as well. So.
Absolutely. No, I think that's great. I just want to say, really, Jane, thank you so much for giving us such a clear and honest look at home care in the UK, and really for leaning into this conversation about, global collaboration and how we can better help one another as well.
It's been really good fun. Thank
you. And thank you so much, Jane, from me and from our listeners here in the U.S. And to our listeners, thank you for joining us for part 1 of our International Home Care series.
Yes, and until next time, as always, we want you to stay curious, stay informed, and stay in the hot seat.